Welcome to OsteoBoston. We are a group of solution seekers for better bone health. If you're with us tonight in person, a huge welcome and a quick reminder that unfortunately there's something wrong with our recording tonight, and you'll need to call back in 40 minutes or less as soon as it hangs up. I'm sorry about that, Devanshi, Dr. Devanshi. We also want to say we hope you enjoy tonight if you're here live. If you're listening on YouTube, we're excited as well, and give us a thumbs up if you like it, and it'll help us to understand and to determine future content. If you're with us in person, we have a second hour, hopefully another 40 minutes, where we'll be able to discuss and share amongst ourselves. Anyway, thank you, Devanshi, and I'm going to just let you take over here.
Thank you so much for having me. I'm going to share my screen. Let's see.
Just a second. Let me just. Okay.
Good to go?
Yes.
Okay. All right. So here we go. And I just want to. Okay, can everyone see this?
Yes.
These slides? Okay, perfect. So I'm Dr. Dev. I'm going to be an endocrinology fellow this coming summer, and one of my interests are in bone and calcium disorders, and specifically osteoporosis. Today I'll be talking about both the medication and non-medication treatments of osteoporosis, talking about the vitamin supplementations that we can do as well. So today we'll do an overview of osteoporosis, when in general we should treat it, what type of vitamins we should be taking or not taking, the medication treatments of it, and then how often we should be monitoring this disease. All right. So as we know, osteoporosis is defined operationally as a bone density that falls about 0.5 standard deviations below the mean for young, healthy adults of the same race and gender. And that's referred to the T-score that you often see on your bone DEXA scans. Epidemiologically, we know that osteoporosis occurs more frequently with increasing age as bone tissue is progressively lost. And moreover, the fracture incidence also follows similar trends as well. So as we can see here in this graph, the fractures at the distal radius increase in frequency typically before age 50, but then only kind of plateaus after that. In contrast, incidences of hip fractures due to osteoporosis double every 5 years after the age of 70. And this is thought to be due to the way that people fall as they age, with fewer falls happening on an outstretched hands and more on a hip. And then to give you the degree of the osteoporosis burden that's just present in the world, just in 2000, a study was done that showed about 9 million osteoporosis fractures happened just in the year 2000. I wanted to briefly talk about why osteoporosis happens, because that kind of plays a role into how we actually treat it. So in general, I think of osteoporosis as happening due to a balance of both damage with stress that happens on the bone, as well as the need for calcium supply in our blood. So and that in general is a constant regulation that happens during life. And in addition to this balance, there's in general multiple circulating hormones, including estrogen, vitamin D, which is just a vitamin, parathyroid hormone, as I'm sure some of you have heard about, as well as parathyroid-related hormone, and then growth factors as well. And then the cytokine that's important for regulating these osteoblasts, which build bone, and then osteoclasts, which break down bone, is called RANK-L, or ligand, which is typically expressed on the osteoblast cells. And it results in kind of communication between these two things. It's also been shown that estradiol, which is a hormone that we have, typically limits the release of RANK-L, and the estradiol then prevents osteoclasts, which breaks down bone, prevent from differentiating and becoming kind of mature cells. And that's the reason why postmenopausal women are more susceptible to osteoporosis, because when you lose your estrogen, you're losing the inhibition to osteoclast maturation and you're increasing your bone resorption. I wanted to talk about briefly the other risk factors of osteoporosis. So interestingly, there's been quite a number of studies that's done in rural communities where people, are farming or, more on their feet, are walking a lot or having a little bit more exercise. And those people actually have had lower rates of osteoporosis. And it's also been shown that athletes also have a higher bone mass than the general population. We know that medications play a large role as well, specifically steroids, and also some of the cyclosporins, cytotoxic drugs, excessive alcohol, and then cigarettes as well. And cigarettes have been shown to be detrimental to bone mass either by indirectly modifying estrogen or by direct toxic effects on osteoblasts to build the bone. I want to talk about when we treat now. So now that we did just a basic overview, it's important that, when you get your DEXA scan report from your doctor, when do you treat it or when do you have to? And this is the guidelines that have been published and recommended and what I do in my practice as well. So in general, pharmacological therapy is recommended if you have, for postmenopausal women with a history of a fragility fracture or with osteoporosis based upon your bone mineral density score, T-score less than or equal to negative 2.5. And then particular attention should also be placed on treating women with a recent fracture, including a hip fracture, because they're a higher risk of actually getting a second fracture as well. This is just an example of what you would receive in your report. We also suggest pharmacological therapy for the treatment of high-risk postmenopausal women with T-scores in between -1 and -2.5. And we also calculate the fracture risk assessment tool, the FRAX score, which is a reasonable threshold to define a 10-year high probability of hip fracture or a combined osteoporotic fracture of 3 or 20% respectively is generally what we use in clinic. And that will help you kind of guide if you need to be on therapy or not. Now, what about the non-pharmacological approaches? So we hear medication, 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 but what can we do that is non-medication related and when should we do it? So I wanted to talk about a recent study that's actually been come out. It was actually a very large study that was published by the New England Journal of Medicine. That was published actually just this year. And it found that vitamin D supplementation actually didn't prevent fractures in healthy adults. So the study was done in order to understand whether healthy people without vitamin D deficiency or bone disease should take vitamin D for their bone health. I have to say though, in looking at the study in this group with overall healthy bones, vitamin D, although it wasn't associated with a lower risk of fracture, it did not answer the question of whether people with bone loss should take vitamin D. So in this study by the New England Journal, a very small proportion of people had osteoporosis. And it appears that within this group with osteoporosis, vitamin D may have decreased the risk of fractures by about 25%. But we cannot say that for sure because the study was underpowered. So in summary, I would say that I continue and many physicians continue to recommend vitamin D to our patients with osteopenia and osteoporosis. However, it has not been shown to reduce the incidence of fractures in otherwise healthy adults. You don't have to take it if you don't have evidence of bone disease. If you do have osteoporosis, and to delve into this a little further, the general vitamin D recommendation in postmenopausal women and calcium should be this. Generally, calcium is recommended about 12,000 milligrams daily total, and about 800 international units of vitamin D daily. And then premenopausal women or in males with osteoporosis, 1,000 milligrams of calcium is recommended at 600 IUs of vitamin D are generally advised. I also wanted to talk about vitamin K. It's a vitamin that we often don't think about and related to osteoporosis, but this does actually play a role in bone disease. So typically adequate vitamin K status is required for carboxylation of osteocalcin, which is a hormone secreted by osteoblasts. So if you are in a state where there is impairment in vitamin K metabolism, such as people on warfarin use, that's been associated with actually reduction of bone mass. So that should be thought about as well. Now let's talk about exercise. So there's been a lot of talk about what kind of exercise should be doing. Should it be weight bearing, not weight bearing? What does that even mean? And in general, the recommendations are that individuals with osteoporosis should engage in weight bearing exercise for at least 30 minutes a day on most days of the week and incorporate muscle strengthening exercise and posture exercises as well, 2 to 3 days a week. For patients with a history of vertebral fractures in their back, brisk walking is safe and an effective weight-bearing exercise. I found this study particularly interesting. This study actually looked at, it was a cross-sectional study looking at 55 male students. And the groups were categorized in people who were basically sedentary, not doing anything, the control group, people who were swimming, and people who were dancing. And that was kind of characterized based on the level of weight-bearing activity. This group then looked at ultrasounds of the heel of these students and looked at the bone density levels in these students, in these subjects. And it was found that overall soccer players and dancers had significantly higher ultrasound measurements than swimmers. And it basically indicated that regular participation in weight-bearing exercises in young people might be beneficial for accruing peak bone mass and optimizing bone structure. So let's talk about the medication management of osteoporosis now that we've kind of addressed the vitamin supplementation and then the exercise component. I got the message. So in terms of medication management for postmenopausal women with osteoporosis, the first line of therapy is bisphosphonates. So we prefer oral bisphosphonates as the initial therapy, one, because of their efficacy, but also their cost, and also the availability of long-term data. The way bisphosphonate works is that it's actually structurally related to pyrophosphates. And what it does is it basically impairs osteoclast function and number. In general, we suggest using alendronate or risodronate as our first choice of bisphosphonates due to their efficacy in reducing vertebral and hip fractures. And most commonly, we actually use alendronate in part due to the direct evidence showing residual fracture benefit in select patients after completing 5 years of this therapy. So how do we take the bisphosphonates? We know that we should be taking it at least 30 minutes, taking it and then sitting upright for at least 30 minutes. And the contraindications are usually when in patients with esophageal disorders, they can't swallow due to the dosing requirements, or in chronic kidney disease. So if your GFR is less than 30. In this setting, if you have GI tract issues or you're unable to swallow, we can use IV bisphosphonates, and typically IV zoledronic acid has been demonstrated to reduce vertebral and hip fractures. I wanted to talk also about denosumab or Prolia. And this is an alternative to IV zoledronic acid, and this is used for women at high risk of fractures, such as older patients who have difficulty with the dosing requirements of oral bisphosphonates, they can't take it weekly, or who prefer to avoid IV bisphosphonates due to side effects like the acute phase reaction, or in patients who have impaired renal function. So it is first line if you meet those criteria. The way it works is that it's actually a monoclonal antibody, and it inhibits rank L that we were talking about earlier. And by doing that, it basically decreases bone resorption. There was a big trial called the Freedom Trial. And this basically was a study that enrolled 7,000 postmenopausal women with osteoporosis. And they demonstrated that 60 milligrams of Prolia every 5 months for 36 months significantly reduced the risk of hip, non-vertebral, and vertebral fractures compared to placebo. The thing to know, however, about Prolia therapy is that in contrast to patients with bisphosphonates, patients treated with denosumab should not have a drug holiday after a given period. Oral alendronate specifically has been shown to maintain bone density after discontinuation of denosumab. And this in general can be initiated 6 months after the last denosumab dose and should be continued for at least 1 to 2 years. So denosumab in general should always be followed with an anti-resorptive therapy afterwards, after you stop the denosumab. So what do we do for patients with severe osteoporosis? So this is a whole separate group in patients with a T-score of equal to or -3, even in the absence of fractures, a T-score of less than -2 with a fragility fracture or several vertebral fractures. In this scenario, several physicians actually suggest starting treatment with an anabolic agent So some examples of these would be teriparatide, abaloparatide, or romosozumab. And the way they work is, for example, teriparatide is a human PTH analog, a hormone that we produce in our body. And it was actually the first anabolic treatment that was approved for osteoporosis. It mimics the physiologic actions of PTH and stimulating new bone formation on the surface of bone by stimulating osteoblastic activity. Furthermore, in trials comparing teriparatide with risodronate in postmenopausal women within severe osteoporosis, there were fewer new radiological vertebral fractures in the teriparatide group. So it is a good option in these patients with severe osteoporosis. I wanted to talk more about romosozumab, which is newer in the sense that it was FDA approved in 2019, so about 3 years ago. This is one of the anabolic agents that I was mentioning in patients that are recommended in patients with severe osteoporosis. And the way it works is that it's, again, another humanized monoclonal antibody, this sclerostin, which is basically a cytokine that inhibits bone formation and stimulates bone resorption. And by blocking this cytokine, this medication actually has a dual effect, and it increases both bone formation and it decreases bone resorption. The caveats of this medication is that it has only been studied for use in up to 12 months, because after that, basically it has not been shown to maintain bone mineral density. In general, patients with severe osteoporosis who are treated with an anabolic agent are similarly also afterwards treated with an anti-resorptive agent, such as a bisphosphonate after discontinuation. And that basically preserves the gains in bone mineral density achieved with the anabolic agent. And for women who are unable to follow these anabolic agents with a bisphosphonate, options include denosumab or raloxifene. I wanted to touch on the SERMs because this is another class of medications which can be used in some patients in some scenarios that I'll discuss. So this is actually called selective estrogen receptor modulators, and they basically bind with high affinity to the estrogen receptor and have both estrogen agonist and antagonist properties that vary depending upon the individual target organ. Examples of SERMs are raloxifene, azadoxifene, and they have estrogen activity in bone, and therefore they prevent bone loss. Since the anti-resorptive effects of raloxifene are less than those of bisphosphonates, we reserve this medication for a specific group of person. So we reserve it for people with osteoporosis and no history of fragility fractures who cannot take bisphosphonates or denosumab, Prolia, or who have an increased risk of invasive breast cancer. So there was an interesting study called the MORE study, M-O-R-E, and this study basically looked at postmenopausal women and with osteoporosis who took a medication called Evista, which is raloxifene hydrochloride. And they found that this group of people had a 72% reduction in newly diagnosed invasive breast cancer and an 84 reduction in the risk of estrogen receptor positive invasive breast cancer compared to women who took placebo. So this medication in general, if someone is at risk of breast cancer and who has osteoporosis, is an option. And finally, I wanted to touch on treatment monitoring. So in general, there is not a big consensus on the optimal approach for monitoring, but in general, what I recommend and what many physicians recommend is that for patients starting on therapy, a follow-up DEXA scan of the hip and spine after 2 years is suggested. If the bone mineral density is stable or improved, that can be spaced out. Many people then ask about, should we check serum bone turnover markers and monitor those? And it's not necessary. However, for some patients who have conditions that may affect with the drug absorption or the efficacy, if they have a small bowel resection, or if they have other types of malabsorption, it can be used because then we typically measure a fasting urinary N-telopeptide or NTX, or we measure CTX 3 to 6 months after starting bisphosphonate therapy. And so to summarize what I went over, in general, lifestyle measures we know should be adopted universally to reduce bone loss. In patients with osteoporosis, vitamin D and calcium are recommended. However, in patients without bone disease, osteopenia, or osteoporosis, it is important to know that vitamin D has not been shown to reduce the incidence of fractures. In postmenopausal women with osteoporosis, such as E-score negative 2.5 or fragility fracture, the first line medical treatment is a bisphosphonate. However, if a person has CKD, has GI distress, or in the sense that they cannot take weekly dosing, they cannot, they have esophageal motility disorder or absorption issue, in those cases, denosumab or Prolia should be considered. And then finally, patients with severe osteoporosis, such as a T-score that's greater than or equal to -3, it should be considered to start an anabolic agent, like the teriparatide, the ramucirumab that I mentioned. And then in terms of monitoring in general, if you start therapy, DEXA scans should be obtained every 2 years, and then can be spaced out if stability is shown or if improvement is shown. And I just want to thank my mentor, Dr. Joy Tsai, who is also on this call and has helped me